The guidelines put forth by NCEP/ATP3 are just way too complicated, which I think I will show. Bottom line is that I have shown in previous videos you should just get the 4 emerging risk factors. If you show the patient has disease, then treat aggressively. The ultimate question is who gets statins? Well, all the guidelines might be listed in a short list as follows: risk factors, Framingham score, NECP, ATP, metabolic syndrome, cardiovascular equivalence, list of items that upgrade risk category. Now, I'd like the doctors to name all these things before viewing the rest of the slideshow and see how close they get. I know that a doctor will say he does this in his head, but that really isn't sufficient when we talk about electronic medical records and trying to document things for the federal government. Well, here's the basic thing that I think just about every doctor agrees on. Based on Framingham results, if you have these risk factors, if you have 1 or less, then you're low risk. If you have 2 or more, you might be high risk or intermediate risk. And in order to determine that, what you need to do is do the Framingham score. The Framingham score is interesting in that it's old, and most of the lipidologists I talk to say they don't use it. And yet, here it is as the basis of the present guidelines. It leaves out, you may notice, family history. It leaves out things like metabolic syndrome, so those things have to be added later. The Reynolds index tries to add on C-reactive protein high sensitivity, and as far as I know, that's just for women so far. But I'm one of the few doctors I know who actually fills out the form and tries to determine the score for a patient, because in Kansas, if you're in the intermediate risk, Kansas Medicare will pay for your calcium score if you have an equivocal stress test. Not very simple. Here we go, the risk factors. What's interesting is that after you get the score, you get put in one of these risk categories. And what this means is that, let's say you have 9% risk. That means, I believe, that you have a 9 out of 100 chance of getting an event over 10 years. If you're high risk, then you have more than 20% chance of having an event over 10 years. I think some people might like those odds. However, the low risk can easily be upgraded to the high risk if your coronary calcium score is elevated. In fact, I had low risk patients who had a 0 coronary calcium score. However, when I did a CIMT, they were found to be greater than 75 percentile risk for their age and sex. Clearly, the Framingham is insufficient. Well, the Prove It trial and the HPS came out, and it showed that getting the LDL lower than 70 actually improves outcomes. However, they couldn't really change the guidelines sufficiently because there were other ongoing studies going on. And if you change the guidelines, then that sort of makes it difficult to continue the studies. Politics. Anyway, in 2004, they did their best, and they said if you are very high risk, which means you have CHD plus some of other things that I'll get into later, then it's the option of the doctor to try to get the LDL under 70. Now let's emphasize this point. The option of the physician. Clearly, a physician uses these guidelines as the minimum to treat patients. If he has any concern, he should go on and treat them aggressively. These are the coronary heart disease equivalents, and there's some problem I have with these. For example, symptomatic carotid disease. In other places I have seen that if the carotid ultrasound is greater than 50% blockage, obviously you could be asymptomatic and have a blockage in your carotid of 90%, and it wasn't found until someone did a carotid ultrasound. This is a very interesting list, but I think it just complicates everything. So on my patients in the lipid practice, I will get their risk factors. I will determine their Framingham score. I will write down if they have metabolic syndrome or not. I do this for completeness sake for the electronic medical record. However, I think it's way too complicated for the average practicing physician. As mentioned, it's well recognized in the Bloom and Stone book and the SHAPE trial that you can upgrade risk by doing any of these tests. So let's say I have a patient whose Framingham score is less than 10%. They are low risk, but I'm a little worried because of family history, or maybe they have metabolic syndrome. So I go on to get one of these studies. And I always get the calcium score first because I think it's probably the most sensitive and most meaningful. If it's positive, then they are high risk. The same goes for CIMT. I believe the Stone book says that it has to be greater than 50 percentile risk. To me, if you have plaque, you have plaque, and they should be treated aggressively. In 2004, the committee headed by Grundy tried to figure out, well, okay, we have this information that treating to LDL less than 70 actually does seem to decrease risk. So who are we going to tell people to treat? And so they said, okay, you know they have coronary heart disease based on carotid disease, peripheral vascular disease, having had a heart attack, aortic aneurysm, or diabetes, or having a risk factor greater than 20% on Framingham. Still with me? Okay, now you add on whether they have acute coronary disease, diabetes, metabolic syndrome, severe uncorrected risk factors. You'll see that diabetes is mentioned again because maybe this is diabetes uncontrolled, I'm not sure. This is very complicated.